What is that? What does that mean, and why should we care?
First of all, thank you for letting me participate today. And yes, I have donated a lot of time, and I'm very proud of that effort. And as you look at healthcare broadly, I think there are a few things everybody on both sides of the aisle, all business and providers can all agree with, and that is that the only way to really lower costs is to change outcomes. And when you look at business, when you look at any part of what has worked in truly changing outcomes, whether it's a medical outcome or a business outcome, it usually starts with some form of measurement. And but we all know measurement's not enough. The key is doing something with the measures. And what we found is people have to be motivated to do something. So again, for us, and as we've studied around the world, where have outcomes been changed? It's places where you've collected data, where you've reported those data, and then where providers get together and talk about how to improve those data. So I'm a big proponent of that. It's a fundamental business practice that almost any corporation has used. And again, and what we've seen in Minnesota, Wisconsin, California, and other places is it is a major way to change outcomes. I serve, one of my extracurricular activities is to be on the Quality Improvement Committee at TriHealth, and I've watched us significantly improve on certain quality measures, primarily because the government started forcing certain measurement years ago, and then we added our own set of measures, and then we've gotten providers together to go work on that. So I think it's a tremendous opportunity, and one thing many people here may not realize is we are in a unique position in Cincinnati to take a lead here. We are one of the most wired cities. We have now got one of the largest percentage of our family practice physicians collecting and reporting data. We already have experience in working on quality improvement. This is an area where the physicians themselves have taken an active role in creating the right measures. And again, I think we're way out in the lead and have a chance to really make a big difference.
Excellent points, and one thing I think is really worth emphasizing is the lead that Cincinnati has. I think those of us in Cincinnati, we always assume that everybody else knows more than we do and is doing better than we are. And in fact, we are leading the country in a number of important initiatives. And Bob, I want to turn to you to follow up on that, because one of those initiatives is called the Patient-Centered Medical Home. And you've been working with Tom on that. You and I have worked on that. I know we could spend hours. We have till 8 p.m., right? I know we could spend hours talking about that, but in a few sentences, what is the Patient-Centered Medical Home, and how does that tie back to what Tom was just telling us about the importance of public reporting and giving actionable data to physicians?
I guess in a very brief capsule, the concept of the patient-centered medical home is a transformation of primary care practices, internal medicine, family medicine, pediatrics, to a different model of interaction and supporting their patients. The continuity of care, comprehensiveness of care, personal relationships are still going to be there just the way they are today. But these practices focus much more on quality, patient engagement, team practice, prospective medicine. Give you a couple of examples of how a patient-centered medical home, and we have about 20 in this community, is a little bit different. For many of you, when you want to see your primary care physician, you call and you say, gee, I've got a sore shoulder, I'd like to see Dr. Smith. And the response is, well, her first opening will be a week from Tuesday at 2 o'clock. That's not really highly satisfactory. Patient-centered medical homes, they have moving to open access, so a certain percentage of their appointments every day are open. So you call, you want to see Dr. Smith, the response is, what's good for you, 10 o'clock this morning or 2 o'clock this afternoon? So it makes it much easier for the patient to engage with their physician when the patient needs it. Second thing that is different is how you manage chronic disease. You know, the huge amount of burden in terms of disease for a patient and cost to the system has to do with multiple chronic diseases that we all have after 50 years old. So we have high blood pressure, high lipids, whatever it is, and most of us have 3 or 4. In most primary care practices, because they're so busy and they're just trying to keep up with the demand and the people coming in, you really don't have time or the ability to stand back and say, how am I doing practice-wide? How am I doing on a population basis? Now, you know, if you've got a pet, every year you get a card from the veterinarian that says it's time to bring Fluffy in for her shots. If you go to the dentist, every 3 to 4 months you get a card that says time to come back in for a cleaning. You don't usually get that from your primary care physician, and it's because they're not doing prospective medicine. Patient-centered medical home, there's a conscious attention to how are my diabetics doing? How are my hypertensives doing? How, you know, have I seen this patient in the last 6 months? Do we have a measure of their blood sugar in the last 6 months? If you don't have it, they get a phone call. They get a card. So 2 examples of how the medical home will change the nature of primary care practice.
Very exciting stuff. What I'm hearing from both of you is a lot of focus on how we can improve the flow of data, how we can take that data, give it to not only physicians but also patients. That suggests that we need a lot more what I would call 21st century technology involved in medicine than we currently have. And Maria, you work for probably one of the most technologically sophisticated organizations in healthcare. How do you see technology being a lever to accomplish the kind of things that Bob and Tom are talking about?
I think it's a great enabler. Technology both for the physician as well as the patient. One of the things that we certainly see is the burden in the primary care physician environment in terms of managing not only their patient flow, but also the data. It is a massive amount of information that today, as healthcare and science have evolved, we are able to generate on any given patient. But how do you then take that data and have it be information? And how do you get that information to help you drive the outcome? And so we believe that a lot of the energy we've put into developing algorithms, analysis opportunities that we provide our customers is to try and get to that information. And so whether it's through our direct products in physician offices or our EMR product, and there's many very good EMR products out there as well, it's a matter of electronic medical records. How do you change the behavior so that you're actually looking prospectively at what is that information telling me about my patient population? The other thing that is evolving with technology is its access. So today, physicians can have their desktop on their smartphone. They can, certainly from us, order labs, look at lab and pharmacy interaction for patients who may call end of day, over the weekend. And it's the power of that technology that enables that 24/7 decision making. The other piece of the technology spectrum that we're exploring now, and we think is very exciting, is giving patients access to information that helps them be participants in that care dynamic. So if you're a diabetic, do you know where you stand? I think there's statistics from the CDC that say that something like 85% of pre-diabetics don't know that they're pre-diabetics. So how do we take all this powerful information we have and actually put it in the hands of someone that can do something about it? If you can get the pre-diabetic to take personal action, you are likely to prevent them from becoming a diabetic, and we all know the downstream effect from personal cost and financial cost to healthcare overall. So technology will enable all of those things to happen.
So we're hearing about technology. We're hearing about the kind of structural changes to the system that Bob and Tom are talking about. Tom Urban, you're responsible for one of the busiest hospitals in the Tri-State. I know that you're very involved in bringing technology into Mercy. At the same time, you're facing a huge manpower shortage over the next decade. You know, that other piece, the people who have to use the technology, who have to drive the structural changes. What are you doing about this? First of all, what's driving this manpower shortage? And then what do you intend to do about it?
Yes. When you think about it, it can keep you up at night and give you a few more gray hairs, which I've certainly had since I've moved to Cincinnati 18 years ago.
At least you still have them.
Yeah. And by the way, I'm used to going last on the panel with the last name starting with you. This is fine to go fourth out of four. But manpower and people who are going to be able to care for us when we get older, particularly the baby boomers like me, as we age, that big bolus of Americans as we age, as Dr. Graham said, and the increase in the incidence of chronic disease. I think all of us in this age group worry about who's going to take care of us when we get older. From a health systems perspective, almost all jobs within job categories within a hospital or health system are changing in one way or another, and that starts right at the top for people like me in hospital administration. You know, healthcare executives, this world has been turned upside down from when I started 30-some years ago as a graduate of the Xavier program in healthcare administration. Today, we have to be a lot more agile. We have to be a lot more transparent, as Tom was saying, as it comes to public reporting. We have to learn and feel comfortable working with teams to get things accomplished. That's something that when we started out in school, we weren't used to. And with the onset of something as significant as health reform, we have to begin changing the way we look at the whole health system. And an example of that is like this. Probably wasn't 10 years ago when I would walk into a hospital, and I'm a very happy person when all the beds are filled, the surgery schedule is chock full, the emergency room is holding patients, and my life is good. That's not how my world is today and will be in the future, and it's changing right before our eyes. I'm going to be happy and thrilled very soon when I walk into Mercy Hospital Fairfield and it's empty or half empty. In the emergency room, there's no waits. Because if that indeed day comes and that happens, that will mean we're being very successful at taking care of people and keeping them out of the hospital, keeping them out of the expensive ED. Population health is replacing the healthcare world that I grew up in. In addition, medical records personnel, laboratory personnel, nurses, almost every job description within a hospital is not just changing, but experiencing a shortage in the years to come. So one of our major initiatives is reaching into high schools, especially partnering with colleges and universities to see how we can have adequate training programs for the health personnel of tomorrow. And one last point has to do with physicians. I'm sure Dr. Graham knows these statistics, and you do, Derek, better than I. But the number of people choosing the medical professions is also declining significantly. So physicians, primary care physicians, or even some specialties are facing a significant shortage in the years ahead. So we'll see a growth in physician extenders, nurse practitioners, physician assistants, and the like. And we'll have to surround those physicians, as Dr. Graham mentioned in his description of the medical home, with other types of providers that can assist the physician in caring for their patients and keeping them healthy.
So the bottom line is tell every kid under the age of 15 to go into some aspect of medicine.
Health is still a growth industry.
It still is. You know, I want to stay with you for a minute, Tom, because you're talking about manpower, you're talking about how Mercy is really, in many respects, changing its mission. You've also been very involved in the last couple of years, like all the health systems around town, and I would say in communities across the country, in acquiring primary care practices and now even specialty practices. You told me you've gone from 40 employed physicians to now well over 200. Okay, you've got these 200 physicians who are now Mercy employees. Now what? And what does that mean for the community?